Live.
Okay. Good afternoon and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We have 4 bills on the agenda today, and these are work sessions with potential votes depending upon whether or not the bill is ready for that. And we want to make sure that each bill gets the time that it needs to get the feedback and input from all the different perspectives to make sure we've got the best work product. So given that, we are beginning with House Bill 1034, Prescription Drug Affordability Board, Plan of Action, Repeal of Date for Submission. Lisa, would you tell us what the bill does?
I think the title pretty much sums that one up. It gives the date by which the Prescription Drug Affordability Board must submit a plan of action, if drafted, to the Legislative Policy Committee.
Right. So very quickly, this bill just says that we're going to give the board a little more time to do its work. It was sort of hindered by a number of things, COVID being one of them, but also making sure that they had the resources, the funding resources that they needed to be able to accomplish their work. So we think we're now in a good place for that. So is there somebody who's willing to move there's no amendments, right? Let's somebody move the bill.
Move the bill.
Second.
Is there any discussion on the bill? Hearing no one. Those in favor of the bill, please say aye. Those opposed, please raise your hand in the participants panel. Are you raising your hand, Delegate Saab, in opposition or a question?
Yes,
Okay.
opposite. I mean, I understand the bill. I've just never been a fan of the board. I just don't think, I don't believe in the way it's drafted. So I'm a no.
Okay, great. Thank you. Okay, so the bill passed. And we will move to the next bill, which is House Bill 123, Preserve Telehealth Access Act of 2021. So let's let the folks in for 123. And I will explain my hope that we're going to be able to achieve here today. Are we? Okay, so are we all here? Okay.
Getting there.
Okay.
So many people.
Okay. Yeah. Okay. While we're admitting folks, I want to remind the subcommittee that the reason this bill is back to us, when we had completed our work last week, voted unanimously for this bill to move forward. There were a couple of issues raised around clarity and the distinction between the differences in the Medicaid program and the commercial insurance market. And so in conversations with the Senate staff, they decided to take a stab at what that clarifying language might look like. And I thought it was most prudent and transparent for us as a subcommittee to take a look at this, just to make sure that we didn't do anything, that this new language has no unintended consequences, and that literally just clarifies the issue that was raised by Kathleen Longren and Delegate Krebs last week. And so I do not want to belabor this bill. I think we've come to a lot of agreement. So the question is, does the new language present us with any unintended consequences? I'll remind you that the intention of the bill is to maintain the status quo with respect to telehealth, all forms of telehealth, for the next 2 years as we study it, so that there can be recommendations in the 2023 legislative session about how best to make use of this very valuable tool. So Lisa, do you want to just quickly review the changes in the bill?
So on page 8 of your packet, that's where we are removing the cross-reference to 15-139 of the insurance article. And the new incorporated provisions are subsections C through D. And then also the second part of that was just because of the complication of doing that, it was a little bit difficult to have the separate sunsetted section. So we, the sunset is a separate sunsetted section for the reimbursement language. So rather than having a separate section of the bill, we incorporated dates like we did for the audio only. And those changes can be found at the top of page 9 and on page 11.
Okay, I'm going to ask first for questions from the subcommittee members themselves. Are there questions from the subcommittee members? Okay, let me go to the top. All right, seeing none, then let me open it to other participants for the purpose of, does this language raise any concerns or potential unintended consequences? And if you believe that it does, please use the raise hand function in the participants panel. Okay. I am, okay. Tricia Roddy from MDH.
Yeah, I apologize, Delegate Cullison. I got on just now, so I don't know if we're just talking about that one section of the bill or if we're talking about other provisions in the bill as well.
And you have concerns in other parts of the bill?
So specifically, yes. So we just wanted to clarify. We've mentioned it in a couple of the work groups prior to the subcommittee meetings. So just in terms of reimbursement for facility fees or room and board charges within the language of the bill. So just to clarify, that's not something that was included in the department fiscal note or budgeted. And so that would be outside of what was agreed upon with the Department of Budget Management.
So what we, and Lisa, correct me if I'm wrong, what we've tried to do with this language is maintain what is current practice. We are not trying to change any of the operation or implementation of the facility fees beyond what is current practice for the next 2 years. Do you feel like this language does change current practice?
It does. So right now we do not pay hospital facility fees, and we do not obviously pay room and board charges. The HSCRC has not allowed it for the HSCRC regulated hospitals. I know there's language in there that allows HSCRC to set rates for hospitals, but you have to remember that HSCRC doesn't regulate all hospitals. Payers, including Medicaid, have a considerable number of agreements with DC hospitals and other hospitals. So the language isn't broad enough, and they are new services and costs to the department.
Do you have a specific reference page in line? Go to?
If you add the bill, add some language. It would probably be under the section where it talks about that the reimbursement would be the same as in person. And that we would have to put some language in there that would say that that does not include facility rates or room and board charges.
Delegate Cullison, we have some language that accomplishes what Tricia is trying to do. Just our concern when I spoke to you about it was that currently there is not anything in statute about the unregulated facilities. And so I'm not sure, it might be Medicaid's policy. I'm not sure how that's working out right now, but the concern you had raised to me was you were just trying not to put any regulations in place that aren't currently.
So the whole issue comes up if you have to pay the equivalent of an in-person visit. And so again, we don't pay right now when the service is delivered via telehealth a facility fee. We pay for all the medical services and professional fees, but we don't pay for the facility fees. And similarly, we've pointed out in a couple of instances. So for Medicaid is different than other payers where we cover residential services. And they have room and board fees attached to those services. And of course, we wouldn't pay a room and board fee unless the individual was actually at the facility receiving services.
Okay. The language that we have, Lisa, does that address what Tricia is raising and doesn't change anything that what Tricia said is currently what's happening?
I mean, I know Tricia's seen the language that the Senate has drafted, so I think it accomplishes that, but I'm not sure what other stakeholders' opinions is of that.
Okay, then let's check. Mansi, did you want us, Mansi Braswat, did you want to speak to this specifically? Or,
Yeah.
Or is it on another issue?
It's on this. Thank you, Delegate.
Okay.
I think so. We've had some discussion on this issue as soon as the last subcommittee meeting that we had on this bill when it was voted out. And so I think what we would say here is, to your point about not wanting to change what current practice is, we would ask that anything that we're thinking about in this space do exactly that. I think our language around the regulated component with the HSCRC, address that piece. We understand right now the way the structure is laid out, that we have this difference between either it's the professional or the clinic. Also appreciate that Medicaid has some arrangements in place, with other hospitals on this, on the issue of facility fees. I would hope that the language that we would be contemplating or anything we'd be thinking about in this space kind of preserves that piece. And also that we're not doing something to sort of broadly change payment policy in Medicaid, because that's not something that we've talked through in our several meetings on this bill.
So the language in the commercial part, the commercial insurance part, with respect to facilities fees, maintains the status quo. And what I'm hearing, Tricia, what I'm hearing you say is that by virtue of the fact that we're saying there's payment parity between telehealth and in-person visit, that automatically includes insurance fees, facility fees?
Well, if you take it on the pure words, right? So if you have to pay like an in-person visit. So if you were in a clinic, a hospital clinic, you would get two bills. You would get a professional bill and you would get a bill from the hospital for the clinic fee.
Mm-hmm.
So what we're saying is, and what we allow for is the professional fees. And we do not allow for the clinic fees.
And that's what is current practice.
That's what's current practice. We've allowed one or two exceptions, which I think the language that Lisa has talked about would still comply. It's if the hospital is not able to bill the professional fees separately. So that would cover that. But if you did not include broader language beyond what's regulated by HSCRC, for one, it assumes then that HSCRC wouldn't allow the clinic rates to be billed in order to not incur new costs to the Medicaid program. And then secondly, obviously we have hospitals, lots of business and services are delivered by DC hospitals and other out-of-state hospitals.
Lisa, do you have the language in front of you that might solve this issue? Yeah. So while she's checking that, Tricia,
Sure.
right now, if the person is on Medicaid, what you're paying for, what Medicaid is paying for a televisit is the same as what they're paying for an in-person, correct?
Except for the facility rates. So we pay all the professional fees, but in order to have the facility bill directly or included in the service, you actually have to be in that facility space. You can't be off that location.
Right. But so my point is that I'm not sure how the current language jumps us to the facility fee. If we're keeping everything status quo, what exactly you're doing now, I guess I'm not sure why so in Medicaid sets its own rates and pays at its own levels and out of its own bank account. So if we're just maintaining everything as it is now, this language wouldn't require the facility fee. And I know that we're going to be facility fees is going to be part of the study, the bigger study. So like I said in the beginning, the goal is to keep current practice in place.
So by the face of it, I wish I could be assured that it doesn't mean that facility fees are attached to it. Because we brought it up in a number of work groups, and it still seems there to be some confusion there. So if it's the same as an in-person, then you get two bills. And so if you take it on the face of it, you would get two bills if you read the language. And again, we don't cover the facility fees. So if I put that in regulations, I would be saying hospital providers cannot bill. Their professional staff can bill, but their hospital providers cannot bill.
Is that current regulation?
We say hospital providers can bill, but then we exclude the facility rates. We do.
So that's current regulation. That's current practice. So if we're
I just want Monsi to understand what will be in regulations, that hospital providers are not allowed to provide telehealth. They're only allowed to bill the professional services outside.
And as is currently happening, right?
It is currently happening. I think the language in the bill is a bit confusing when it says it has to be covered like an in-person visit. So I do worry about it, because the same as in-person is the full amount. It has two bills attached to it.
Right. I'm going to look for some folks to have some thoughts on this because I'm afraid.
Do you want me to read what the language would be?
Yeah, go ahead, Lisa. Tell us what the language might be.
So if you go to page 9 of the reprint, what is G3? So you would have a Roman numeral 1 from July 1st, 2021 to June 30th for that language. And then there would be another paragraph below that would say the reimbursement required under subparagraph 1 of this paragraph does not include clinic facility fees unless the healthcare service is provided by a healthcare provider not authorized to bill a professional fee separately for the healthcare service or any room and board fees.
Okay. So I'm going to look to the committee now, given the language so let me ask this question. Tricia, does that language get to your issue?
That works perfectly.
Okay. Looking to the committee now for thoughts on the amendment that Lisa just read. Delegate Saab.
Thank you, Madam Chairman. I just want to get clarification on one thing that I think Tricia brought up. So the provider has to be at the facility, or can they be from their home working remotely? doing the service? Because I thought you said the provider has to be at the facility. I just want to clarify that this is not.
No. The provider can be outside of the facility. There are special requirements for certain providers where either the person or the practitioner has to be within the four walls, but generally they can provide it outside. What we're saying is, in order to get a facility rate or a room and charge fee or revenue collected by the Medicaid program, the actual patient needs to be in that facility to get those facility costs attached to the service. We'll pay all the professional fees, but not the room and board or facility fees unless the patient is in that facility.
Does that help, Delegate Saab?
Yeah, Madam Chairman, just a quick question on, I think Lisa just clarified that, but for the purpose of reimbursement and the fidelity standard established, what does that mean by provided by third-party vendor designated by the program? Can Lisa explain that to me a little bit more? It's the number, it's I on page 9. Where it says, subject to section G2 of this section, the program or the MCO that participate in the program may not impose a condition or reimbursement as covered healthcare service delivered through telehealth service be provided by a third-party vendor. Can you just expand on that and explain that a little bit more?
I think that, and I'm gonna, Kathleen, I'm gonna look at you. Can you interpret that for us? I mean, I can make an interpretation, but I want to talk to somebody who is more knowledgeable about the practices here. So basically what it looks like is that the Medicaid and managed care organizations can't say that a third party has to provide the telehealth services. So it can be the vendors that they are currently working with. Kathleen, on that?
So I appreciate the question, Delegate Collison. This piece is puzzling to me in its application to Medicaid. I thought it was there because of concerns in the commercial market with TPA type arrangements or self-insured plans. In Medicaid, and you have this in the bill now, there's a prohibition against making the Medicaid program, whether it's fee-for-service or MCO, paying for services that are provided by an out-of-network provider. And so as an MCO, I may have contracts with a particular vendor to provide dental or other services. And I don't think the intent of this language was to preclude that, but it seems to suggest that. I don't know that this language even belongs in the Medicaid section, but I don't have the benefit of understanding the origin or the purpose. But I think in the Medicaid program, when we have to go out of network, say because we don't have sufficient providers, we have to enter into a lot of times single contract agreement or agreements to provide those services, and it's very detailed. And again, you wouldn't want that prohibited here either.
Yeah, well, I think my interpretation is that there are, there can't be any restrictions on who has to deliver the telehealth based on, current relationships that the MCOs have.
And I think I think what you want is you want an MCO to be able to provide services in accordance with the Medicaid rules, whether it's in person or telehealth. Right. You don't want that distinction.
Yeah, I think that's it too. Delegate Saab, does that help?
Yeah, like I said, I just wanted to make sure that we're not constricting.
We're not constricting, actually.
The delivery of service.
Right.
No, I know that's what I just wanted to clarify. And I was just curious, why was it in this section? But yeah, thank you.
Yeah. Delegate Krebs.
I appreciate you trying to do work about the fee, because that's in my notes of being a big concern. And we've had lots of discussion in this committee about facility fees. And in some cases, they're more than the actual office visit. And I heard what Lisa said, and clearly the whole discussion of facility fees a couple of years ago was, hey, the facility was there. If there was a problem, they could then take you to the emergency room. So you should pay this fee. We are talking about someone that's not presently there anymore. They're at their home. So the whole notion of a facility fee, we need to make sure there's no nexus anymore, whether we, there's no nexus at all with telehealth having a facility fee on a provider. I don't care where the provider is sitting. So I want to make sure that that language, I heard her read it. I've got so many copies of this bill, even from today. I don't look at the right copy. I want to make sure that the carriers too, I see Deb's there, make sure that they're reading it the same so that there is no question that facility fees will not be paid on these visits if the person's not there. I hear what you're saying.
And that's actually not the case, Delegate Krebs. The bill, the way it stands right now, allows for the collection of the HFCRC to implement the facility fees on when they are currently doing it, whatever is current practice. Remember, we're studying this. We are trying to keep things as they are right now. The facility fee question is one that you're right. We are going to be debating, into the future as well. But for the purpose of making sure that the telehealth aspects can go forward, we want to keep everything stable so that we can study it. So,
but you just mentioned HFCRC, everything's the same, but is it the same with regard to telehealth as it is?
Yes. See, but remember, we're looking at two parts of the law here. One is Medicaid, and Medicaid does what we just heard. Medicaid doesn't pay facility fees. So that's the issue. In the other part of the bill, the commercial part of the bill, we are saying HFCRC has the same authority that it has right now, period. So,
but does it allow it for telehealth to have facility fees?
It doesn't say that. The language doesn't say it. It has broad authority to implement facility fees. It doesn't have to, it can, but we've left it open because we're allowing things to stay the same as they are right now.
So right now, today, during the emergency telehealth, are they being billed for facility fees? The private insurance companies? Not Medicaid, but regular commercial, not private.
Okay, can I ask, actually, Jennifer, can you answer that question? Jennifer Witten? If facilities fees are being paid, or is Megan on the?
Yes, thank you, Delegate Collison, and thank you, Delegate Krebs, for the question. So just again to re-emphasize, and I don't see Megan, that HFCRC does set the facility fees for all clinic rates, regardless of the service. And there was some policy consideration during the pandemic as we sort of shifted some of the services out. But again, the reimbursement is really, as we think about this legislation, is really for that professional fee. Now, I will say that on a broader concept, HFCRC has talked about looking at telehealth, but also other ways that we're delivering care as we're shifting care out of the hospital. So there are broader policy conversations, but as it relates to regulated space, HFCRC does set any of those fees associated. So
that didn't answer my question. In the state of emergency during weeks of telehealth, did we pay facility fees through the commercial providers? I mean, is that the practice? HFCRC didn't have time. You said we're going to keep the status quo. What is the status quo?
Monse, do you want to jump in here?
Yeah, so the choice has been either the professional component or the facility fee, I guess, in the simplest of forms. And so I think, again, that's why we have the language, and I believe the HFCRC offered up this language. That's my understanding, to say, we've set out a construct for what hospitals can and cannot bill under the facility fee component. It can't be the entirety. They have to choose. We have a whole regulatory construct in this space. And so we would want to preserve that construct, and however they would want to, change it moving forward. That's why the language addresses it that way, Delegate Krebs.
All right, I just need to understand that better.
I'm going to ask Matt Celentano, can you answer Delegate Krebs' question? are facility fees being paid in the pandemic?
So the short answer is yes. And
Okay.
we have been bringing it up since the MHCC work group started. I don't even know when it was, last summer or in the fall. It has been a concern of the commercial carriers throughout this process. Facility fees are being charged to commercial carriers on top of the payment for telehealth services, which we do not think is appropriate.
And I agree with that. And I really think it's a big deal that we need to come up with and not wait for HOC. We need to be clear in our policy that the whole purpose of facility fees that has been argued and argued is because they're could use the services of the facility that's right there. But when you're doing telehealth, the person is miles away. So they're never going to be using that.
Delegate Krebs, we agree with you 100%. And especially with this bill that now phone calls could be charged with a facility fee as well. And it's been a concern of ours from the get-go.
So I think we need to address it somehow clearly in this policy and not punt it to the HSCRC because it's happening now. We need to be clear, but that's.
Again, I think we are trying to make sure that we have all of the information around how things are charged, how things are reimbursed moving forward. That's what we agreed to last week, that we have a bill that we are going to study what is happening currently. This facility fee issue has been in this bill for the last 6 weeks. So.
And I've been asking about it. I've asked about it many times and we keep saying we're going to deal with it. So.
Well, we did with by putting the authority of the HSCRC there.
Well, that's not dealing with it to me. That's punting it to someone else and leaving it.
Well, it is, Delegate Krebs, except that if we're looking at the overall purpose of this bill, then and we know that the facility fee in and of itself has been a topic of several discussions and bills. Now, we also know that we passed a bill last year that said if there is a facility fee, the provider has to provide information to the patient explaining, that there's a facility fee, how much it would be, and give the patient options about whether or not they want to have the service in that way.
And Madam Chair, let me just give an example. And this just isn't to protect the commercial carriers. This is to protect all of our constituents who have these high deductible plans that make a phone call for telehealth. And are they going to have that discussion on the phone for telehealth? Oh, you might be charged a facility fee, even though you're sitting 100 miles away from this hospital. And so it's not just about the healthcare carriers. It is about our constituents that have these plans, and they're now paying out of pocket for these facility fees that often cost more than the visit itself, the televisit, the actual visit. And I know there's been discussion of why it might be appropriate. I don't necessarily agree, but when you're physically there, but try to explain that to our constituent who gets a bill for this thing and they've been on a phone call. So I don't really want to punt it to the HSCRC. I want to make a clear policy delineation that telehealth cannot charge a facility.
But what you just explained is currently happening.
They just said they're being charged. They just said they're charging facility fees.
Right, and they are currently it is that. So again, if we're looking at the impact of current services in order to make recommendations, and we keep things status quo, I just think that regulating facility fee in this bill will cause the bill to have a lot more struggle in terms of how.
And I'm not talking about regulating. I'm talking about giving the HSCRC clear direction that we don't want facility for telehealth. And during the state of emergency, we didn't have time to figure all this stuff out, but now we do.
Okay. All right, Megan is here now. Megan, you want to speak to it, please?
Yes, thank you. And I'm sorry, I didn't have the Zoom link, so it took me a little bit to get in when I was hearing this on YouTube. I want to clarify HSCRC's policy, which is described in the memo we sent to the work group a couple of sessions ago, to the subcommittee a couple of sessions ago. Our policy during the pandemic has been that in HSC regulated facilities, which as Tricia has noted and others have noted, is only a subset of the facilities that I think is under discussion right now. In HSC regulated facilities, we have a policy that clinic fees, which are facility fees, may only be charged when the provider providing the service cannot bill themselves. So when we've been talking about two bills, the professional fee bill and the facility fee bill. What our policy says is when the professional can bill themselves, they can bill that professional fee. We do not pay a clinic fee. When the professional cannot bill because of billing rules, whatever they may be, then the facility can charge the clinic fee as a way to get paid for having provided that service. So yes, we are allowing for the payment of facility fees, but it's in a very specific and limited situation where there's no opportunity for the professional fee to be paid.
And that's been the practice under the pandemic.
Under the pandemic since April.
And that's exactly what Tricia Roddy is looking for in Medicaid. Right? She wants that kind of assurance.
Yeah.
You're not going to get charged for right.
Yeah,
no,
I don't want to
I'm
speak for
just saying.
Tricia.
Okay.
Yeah, and it's be broader than HSCRC. So the same language would apply to all hospitals.
Right. So the question is,
Do you mind if I follow up with Megan on that? Because she just gave an explanation to my question. So Megan, thank you for that explanation. So in the situation that I gave before, someone with a high deductible plan, and they're now doing telehealth and they make a phone call, would they be able to get a facility fee on top of their bill? They're going to have to pay because it's high deductible. Would they?
So they're either going to get a professional fee or a facility fee. They're not going to get both. Right.
So why would somebody bill you a facility fee? Like, I have a doctor's visit, I have a telehealth visit for X. What's my bill going to say?
So I may ask Tricia to help me out here a little bit, or Matt, but there are some kinds of healthcare providers that cannot bill a professional fee independently. So they can't send you the doctor's bill. Right. And so in that situation, when the person is tied to a regulated facility, we allow a clinic fee so that they are getting paid for having provided that service.
But it wouldn't be any more than they would get for a regular visit fee, like the regular televisit fee.
I don't know if the rate is different than the professional fee, because we don't regulate the professional fees, we regulate the clinic fees, but they would not be getting two bills, right? They'd only.
But I'd like them to make sure they got the same amount it would take if they went to someone else, or the guy that's practicing in the clinic here, would he charge somewhere else? I just don't want someone getting a bill saying, is it a clinic fee and it's $500, but the charge should have been $100.
I can take that back to our folks and provide you some follow-up information.
Thank you.
and how it compares, right?
Yeah.
So my question is, I'm going back to Tricia, and then hopefully this will wrap it up. Given what we know from Megan around what the intent of the HSCRC is and what the practice has been, do we need the additional information in the bill, or can we leave it as it is?
Yes, you do. So again, she's only regulating HSCRC. It also assumes that HSCRC will continue the same policy. But so we need language that clarifies, that goes beyond, because again, they're a large piece of our hospital providers, but we have a significant amount of business that's outside of HSCRC and in DC and other parts of outside of various states. I'll just clarify in terms of, so a good example of a provider that would be providing a clinic fee would be PT, OT, and speech. So those are not providers usually in hospitals that bill separately. They're professional fees, they're part of a clinic visit. Because of the pandemic, we knew that we had to quickly allow them to bill. So we didn't require the hospitals to enroll their therapists separately and bill separately. So we allowed them to bill the clinic fee when they were providing those services. But the idea was that eventually, when we had more time available, the therapist would bill as a professional and not as part of a clinic fee.
So my question to the committee is, are you comfortable adding, we can vote as an amendment, the language that Lisa read off that would, in the Medicaid program, clear that facility fees as separate fees would not be paid unless the provider could not bill for professional services. Is that right? Okay,
I like it.
you're gonna move it, Delegate Kelly?
Sure, move
As long
it.
as Tricia, if you're okay with it, I don't have it in front of me. Hopefully
Yeah,
you're okay
I'm
with
fine with it. It's great.
Okay,
It works.
And I will move it.
okay, Delegate Kelly
Second.
moves. Do I have a second?
Second.
Okay. Any discussion of the committee on this? Seeing no committee hands. Those in favor of this amendment, please say aye. Those opposed, please put your hand up in the participants panel. Okay. All right. It is unanimous, so we will add that language. Any other pieces that were added that are problematic? Going once, going twice, going 3 times. Do I have a motion on the bill as amended?
Move the bill.
Do I have a second?
Second.
Those in-
Second.
Thank you. Any further discussion on the bill as amended? Okay. Those in favor of the bill say aye. Those opposed, please raise your hand in the panel, in the participants panel. Okay. All right. The bill passes unanimously as amended. Thank you all. I'd like to move now to House Bill 780, Maryland Health Benefit Exchange, state-based young adult health insurance subsidy pilot. Lisa, tell us what the bill does.
This bill requires the Maryland Health Benefit Exchange in consultation with the insurance commissioner and as approved by the MHBE board to establish and implement a state-based young adult health insurance subsidy pilot program. In fiscal years 2022 through 2022, the 2022 through 2024, the governor will designate funds from the exchange fund to be used for the pilot program so that 10 million in annual subsidies may be provided in calendar years 2022 and 2023. There's an amendment on page 18 in your packet. The amendment alters the income eligibility parameters MHBE must consider from between 133% and 140% of the federal poverty level to between 133% and 400, which it was actually the 140 was a typo. So that's correcting that. And then the amendments also authorize the exchange to designate up to $2 million for the subsidies rather than requiring the governor to designate the 10 million.
You mean 20 million, not 2 million.
20 million and 10 million. Yep. Sorry.
Right, okay. Up to 2 million or not 10 million. Delegate Kerr, would you like to speak to your bill for a minute?
Just a reminder to the subcommittee that this bill seeks to get the 6% of Marylanders who remain uninsured. These tend to be younger Marylanders who make just a little bit too much money in order to qualify for federal subsidies. What we're looking to do is to provide some state subsidies that would bring the cost of this insurance down so that they would be more attracted to and enticed to take on this health insurance, and it would achieve 3 things. One, it would lower the risk pool because these tend to be younger, healthier people. It would also set the long-term stability of the health insurance exchanges. And it would just, it would spread the risk. So this would accomplish a lot of things, and it would get us closer to having 100% of Marylanders cover health insurance. And we do have Johanna Fabian Marks here from the exchanges, if anyone has any questions.
So let me ask first for questions from the committee. Any questions from the committee or information or feedback? Seeing none. Delegate Krebs.
Yeah, so is this in the budget or is it going to be put into the budget? I mean,
It's coming out of the reinsurance. So, the governor's actually tapping into the fund that already exists. So it wouldn't be in budget in the way that, and actually I should let Johanna answer it because she's nodding in terms of how the funds are actually going to be made available to the state. Johanna, you want to take that?
Sure, yeah. So it's not new funding, as Delegate Collison was saying. It's allowing the exchange to use existing funding for an additional purpose. We've got existing funding for the reinsurance program. This would authorize the exchange to also use a portion of that for the subsidy program.
So the existing funding, and I think as a reminder, by that existing funding that comes from the reinsurance program, tell us where that money comes from ultimately.
Yeah, there's two sources. State funds that come from a 1% assessment on health insurance premiums, and then federal funding that we get to support the program. So we can't use the federal funding at this time for anything other than reinsurance. So the young adult subsidy program would come out of that state funding that comes from the 1% premium assessment.
So on this 1% assessment, tell me who that applies to. Is it just, who all does that apply to? Is it all insurance policies? Is it private? I mean, self-insured, who all does that apply to?
Not self-insured, but most other health insurance policies in this.
So do you have any idea what number of people that is? How many people?
Don't have the number of people.
Lisa, do you have it? It's a huge number, Delegate, because it includes all insurance policies offered in Maryland. So it's your dental insurance policies, your vision insurance policies, your major, health insurance policies. This is a bill we passed, I think, 2 years ago that allowed for us to fund the reinsurance program partially in this way. The other part is coming as the result of the federal pass-through for people enrolling into the exchange.
And did we have a sunset on that? How long that would go on for? I can't remember.
I think is it 23 or 25, Lisa? I can't. We do have a sunset on it.
This bill and the program coincides with the fee. They both are going to sunset at the same time.
And that is, what year does it remind me? I think
it's 2020.
2023 is right.
2023. Yeah.
So another, I'm just make sure I understand this. I don't know if I missed a bill hearing or not, but so the money that we set aside, we don't need it for the purposes we set it aside for a couple of years ago. Now it's just so we can, is that right? That we don't need it for those purposes? There's enough left over that we can redirect it specifically to the Young Health Insurance Subsidy Program.
Right. And I'm going to add that it is a large sum of money that we have in this fund right now. And I want to say it's like $400 million. And when the exchange came to talk to us and give us an update in the fall, it was they who were saying that they felt, given what we can expect from the federal government, although that may decrease slightly, we would benefit by getting more of the young people into health insurance programs, and that it was worth, actually, they were asking for much more money than we're giving them for this pilot. But they thought that it would help, there would be lesser need for the reinsurance program if we could get these young, healthy people into the insurance market. So that was the rationale behind, and it was the exchange that brought the concept to the Commission for the Preservation of the ACA in Maryland. So,
and listen, I am reminding myself, and I know this is a philosophical, I call it a philosophical argument. I don't buy health insurance because it's too expensive and they can't afford it. And, we basically are charging, you just said 400 million extra dollars have been collected from people, current payers, certain current ratepayers, not all of them. If you work for a self-employed place or you work for the government, you're not doing that. But the other ratepayers are paying an extra $400 million over these last couple of years on their own insurance to pay for these programs. And it's just taking money from one person's pocket into another. And I think we should try to get the cost of health insurance and health care down. And all you're doing is keeping it up for these folks that don't even know it by this reinsurance pool. And again, it's a philosophical argument. I won't make it again, but for that reason, I didn't vote for it to begin with when we established it, because I didn't think we should charge one group and pay for another. And I'm going to have to vote against it again for those philosophical reasons.
Thank you, Delegate Krebs. I appreciate that. Debbie Rifkin.
Hello, everybody. I just wanted to just give you a little bit more information. And Johanna, please shake your head one way or the other. Hopefully I'll say it all correctly. We support this. I just want you all to know, but we thought that we wanted everyone to really understand potential ramifications before you vote. And that is that while we have this wonderful pot of money that we can use, reinsurance has been the only thing that's worked that we have found anywhere in the country that has actually stabilized the individual market and reduced rates. And as a matter of fact, there are a number of states that are calling Maryland today, and they probably called some of you, to say, what have we done? Why were we so successful in Maryland, so that they can replicate that around the country? So our reinsurance program will stop in 2023. And if we don't continue, we're going to have potential increases again to where we were before the reinsurance program started. So that pot of money is really important to have for future if we want to continue the reinsurance program, which I pray you all do, or what do we do today with that money? So yes, this would take out $20 million for 2 years, if that's what the exchange wants to do. The two little things I just want you all to understand from the bigger picture is that the federal government has just reanalyzed how much money we will get from the feds. We are going to get over $200 million less this year than we did. I think it's $230 million less. So we're going to be getting not as much. And I do believe in the BRFA. Right now, it's been contemplated that $100 million in fiscal year 21 and 22, is it, will come out for Medicaid funding. And I believe it was really supposed to go for several years beyond that, but I think that there will be an amendment just to focus on 2 years. So you're going to have $200 million potentially coming out for Medicaid, which we also think that's wonderful. You're going to have less $230 million coming in from the federal government. And then this will be up to $40 million for the young adult subsidy. So I just wanted to give you the big picture of what's happening with the money, so that when you think this through, you know what we're going to be doing in the state. But you'll see we also sent written testimony that we support the subsidy that as well.
Thank you. Delegate Lewis Young.
Thank you, Madam Chair. It's my understanding that insurance rates are based on a wide variety of assumptions as well as history. And by getting more young people into plans, it broadens the risk pool. And so I want to direct this to somebody who has direct experience in the knowledge of how rates are established. Doesn't more young people in a pool who tend to have less health vulnerabilities help spread and therefore lower the costs of the general population participating?
So, I mean, in concept, you're correct. I see that Beth Samus is on the call. Beth, is this something that you feel that you could explain in 2 minutes or less? Knowing how complex it is.
Yeah, so sorry, I was sort of tuning in and out, so I apologize for not getting the whole thing. It wasn't that your words weren't incredibly important, Delegate Lewis. But anyways, this is all a debate that we heard quite a bit during the work group that the Maryland Health Benefit Exchange was kind enough to put together over the interim. And that work group. Hopefully you've seen the report. I'm sure that Johanna has shared that with you. The insurance companies brought up the same kind of thing about being concerned about the amount of money, blah, 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 blah. And essentially what everyone else on the work group ended up concluding is that yes, the reinsurance market is very important, no question about it, but that this program, particularly a pilot program, does nothing to put that program into at risk. The reinsurance program will continue, and I am confident that the MHBE will design a program in such a way as to be sure to protect the reinsurance program, because obviously without that, Debbie is quite right, we would the market would be in trouble. So with that said, there are some peculiarities that are a result of the reinsurance program, which we spent a great deal of time talking about in the fall, which is that young people who are below, who qualify for subsidies from the federal government actually pay more of their income now than they did before the reinsurance program. And that's because the reinsurance program decreases the value of the subsidies. So by having the state subsidy program, that will actually bring about the benefits of the reinsurance program to that group of people who are currently being disadvantaged by us heavily subsidizing those above 400% of the federal poverty level. The other thing that this will do is therefore to make it much more attractive for younger people who now will spend virtually nothing for their insurance to come in. They will help to subsidize the pool, bring down the cost, just like you said.
Okay.
So it's really largely for those reasons that we thought that it was important to do this. The second and final reason is that because of things that are just peculiar to the ACA, young people subsidize older people much more than would be the case in a normal commercial insurance product. And therefore, a state subsidy program that targets the young will also help to bring down the costs for them and bring them into the market. So no one voted against the recommendations of the work group. They just raised concerns, as some have been raised here. But I think that really all of us on the work group were pretty convinced that the inequities that we see in the current market would be helped by this reinsurance, using the reinsurance monies to offset some of the peculiarities of the ACA and the reinsurance program, make the market more fair, and thus increase the number of people who are insured and so forth.
Thank you.
Young.
Thank you very much for that very elaborate explanation.
Sorry, sometimes I get so excited about this, I just talk too much, so sorry.
It's okay. I learned a lot.
Okay.
Thank you very much, Beth. That was really helpful. So I'm going to ask the Delegate Krebs.
I'm sorry, Beth, you just brought up something that confused me a little bit. On one hand, you said the young people will pay virtually nothing for this insurance or this program. And on the other hand, you said by them participating in this program, it's going to help subsidize. So how is it that somebody who's not paying anything into something is going to help to subsidize somebody else?
You bring the risk down.
But if they're not paying anything, it's not their money that's helping to subsidize it. It's other money that's helping to subsidize. I know what you're saying, but the pot of money that's being used is not even their own money. It's some money from the reinsurance pool. You know what I'm saying? I can't understand how something can help bring something down that they're not paying in.
Well, Beth, I'm going to take a shot at this. So it is bringing the overall cost of the pool down. You're right, it's not their money, but you're bringing the cost of the pool down. That's what increases the value for them being in the market. with,
But you could infuse that money directly into it and do the same thing. I mean, I don't see how that's up when they don't have any, there's no
how would
skin in
you,
it.
how would you, so the way the money's being used now is in catastrophic instances. So when somebody, I think it's 20, I hope I'm not lying. It's like anybody who has like an over $25,000 bill, and the carriers continue to pay, but the reinsurance pays 80% up to a cap, and I think that's 250,000. And the carrier just pays 20%. That's what's being done now with the money. And that's for those people in those catastrophic situations. You bring these young people in, you take some of that money to build in the young people, you bring down that risk, you potentially get less catastrophic utilization of the funds. And so you're right, it's a way of using the funds to their maximum advantage. It's just a different way of using them. But what the study group is saying to us is this may be a more effective way of bringing the cost down on one side. So,
Okay.
I mean, it's the nature of insurance, basically. And that's what we're looking at, where those of us who, not me anymore, but when I was young and healthy was, contributing to the needs of others. So I'm going to ask, we're just going to do this bill today, and then we have a meeting tomorrow. We're going to be taking on the medical debt bill, and so we will take up 601 tomorrow. But before we adjourn this meeting, I want to see if there's interest in one, taking up the amendments on this bill, and two, whether or not we think the bill is ready to go. So is there anyone who'd like to move the amendments on the bill?
I'll move the amendment.
Do I have a second? I have a motion and a second. Is there any discussion on the amendments? Okay, those in favor of the amendments, please say aye. Those opposed, no. With hands up. Delegate Lewis Young, your hand is up. Did you?
Oh, sorry.
Okay. All right, looks like the amendments pass unanimously. Anyone want to move the bill as amended?
Move the bill as amended.
Okay, do I have a second?
Second.
I have a second. Any discussion on the bill's amendment? Oh,
Yeah, I just have some overall
Okay.
questions on the bill. I mean, isn't this overall going to raise, I mean, it takes money out of the reinsurance pool, correct? That we worked really
Correct.
a few years to put in. And
Right.
transfers that to, why is that a good idea? I mean, we're expanding a benefit to people that were originally drawn out of the bill because of their age, with the theory that they were going to come into the individual market and lower costs from everybody because we had more healthy people in the market. But now we're bringing healthy people that are not paying because of their age and then resubsidizing them. I don't see how that lowers the cost.
They're not paying because it's still too expensive for them. So that's why.
That's the problem with the individual market. It costs too much. I understand.
In general, right. So, again, the way it manages the market is by reducing the risk pool. We decrease the cost of the higher need people because we decrease the risk. It's about just getting those young people into the market. The money's going into the market. It's coming from the reinsurance fund. So it's going into the market. And so now it's being used to address the issues of those who need it more than those young invincibles who can't afford to come in. Does that help, Delegate Morgan?
Yeah, I mean, I understand the theory on that. I just question it to start with. I mean, there's a reason why, the young invincibles, they do have an ability to obtain a catastrophic plan up until what, age 30 or something like that. So they have other instances where they can get insurance that might be more beneficial to them. I just see it, if we're drawing it into the point that the individual market and reinsurance plan was created for an entirely different reason. And now we're expanding the benefit of that, which will ultimately, run out of money and not lower costs.
we hope to prevent that. So, any further discussion on the bill? Delegate Lewis Young?
Yes, now my hand is up.
Right.
I think there's a faulty assumption that there's a one-to-one relationship between investing money into young people versus lowering the overall cost of the program by lowering the risk pool. And I hope this isn't a bad comparison, but I think of it in terms of investing in pension plans or retirement programs. You could invest more money in 1 year, or you could change other variables such as raising the retirement age or the amount that an employee has to contribute. And those two alternatives would not have an equal relationship. The returns would be very different. So I just want to caution those in assuming that the investment versus the return from lowering the risk pool would be equal.
Okay, thank you. Seeing no other hands, those in favor of House Bill 780 as amended, please say aye. Those opposed, please raise your hands in the participant panel. Okay. Okay. Give you another minute. Okay. All right. We have, let's see, there's 12, we have 9 in support, 3 opposed, so the bill passes as amended. I thank you all for these great discussions today. I apologize in advance for those who came to talk about 601. I hope that you will come back tomorrow. And we will be meeting after session tomorrow to talk about 2 bills now. It'll be 601 and the medical debt bill, which is I think 585. Alrighty, thank you all very much and have a great afternoon.